Alright, so we are back doing the videos for a little bit, for the YouTube videos. Hopefully not too many. Anyway, so I went ahead and divided this particular PowerPoint up in two sections. So we cover half of it today, or actually just a little bit less than half today, for Monday, which is June 29th. And then I will do the rest of it on July 2nd on the morning. So I will start that as a live lecture at 8 a.m. So moving forward. So talking about the cardiac cycle with the conductivity of the heart. So we're kind of talking more about the electrical part. That'll actually be the last part of the lecture, where we'll be talking mainly about the EKG and what that looks like and what that all represents. But first of all, we'll be starting by defining the cardiac cycle. So the cardiac cycle is the term that refers to all the events that are related to the flow of the blood that occur from the beginning of one heartbeat basically to the beginning of the next. So your fill in the blanks there are beginning and beginning. Okay, so we have what's being shown there is atrial systole. So the top one, so at 12 o'clock basically, you're looking at atrial systole. So remember that systole again means contraction. Okay, so that's where the atrium meaning plural, are actually contracting and pushing the blood into the ventricles. Okay. And then we have a period of time there at 3 o'clock, which says isovolumic ventricular contraction. Okay, so we have the same amount of volume going on for your ventricular contraction, right before ventricular contraction, basically. So you're filling up the ventricles. And then you have the ventricular systole, which is where your ventricles are contracting. So your right ventricle is contracting, putting out to the pulmonary artery that's going to your lungs, and then your left ventricle then is contracting out to the aorta, to the rest of the body. And then you have the period of ventricular diastole, which is kind of that brief relaxation period where the heart gets ready to go ahead and pump again. Alright, so the frequency then of the cardiac cycle then is known as our heart rate. So every single beat of the heart has basically 3 different stages. So you have that, again, the atrial systole, which is the contracting period, the ventricular systole, again contracting, and then complete cardiac diastole. Okay, so where it's that little brief kind of relaxing period. Okay, where the valves are open and it's starting to fill again, or the electrical, you'll see the electrical threshold is kind of in this like refractory kind of period, recovery period. Okay, so heart rate then is one of our vital signs. It's used to determine or to describe the frequency of our cardiac cycle. So we basically kind of have 5 vital signs. We kind of thrown one of our own in there as far as respiratory that we're concerned of. So we obviously have our heart rate, our respiratory rate, our blood pressure, the temperature, and the 5th vital sign that we like to throw in there is a pulse oximetry, what the pulse ox is reading. So when we're looking at heart rate, we're generally referring to the number in beats per minute. Okay, so it's a heart rate in 1 minute. Is your fill in the blank there, 1, and it's expressed as BPM, which is beats per minute. So your normal heart rate for adults, I don't know, kind of take a wild guess what you think it might be. I'll give you a second just to think about it, and then I'll tell you the answer. So the normal heart rate range is considered 60 to 100. Okay, so 60 to 100 beats per minute. Anything less than 60 then is considered bradycardic or bradycardia. and we'll talk about that in more depth on the next lecture. But it's a slower heart rate, Brady meaning slower. Okay, we're not too terribly concerned if somebody's bradycardic unless they are symptomatic. Athletes are one of the categories of people that are often have a slow heart rate. Their heart rate, their muscle is much more conditioned, and they just, hang out at a heart rate of, who knows, 55, 50, whatever, and they feel fine with that. Now, some people, if their heart rate dropped that low, if their muscle wasn't contracting as well, and we'll define that in a few, called your stroke volume. That's how much blood actually is ejected with each time your ventricle contracts. It's called stroke volume, and we'll talk more about that later. Then they're going to have a low blood pressure and that's when they're becoming symptomatic. So they become lightheaded, maybe short of breath, they might pass out. So that's when we really need to be concerned more so if they're symptomatic. And the same kind of goes on the other extreme. So if you're greater than 100, and don't worry about writing all this down because we'll talk about it more, but I'm just kind of talking here. If you're greater than 100, then it's considered tachycardia, T-A-C-H-Y, tachy. And so that means you're beating fast. Okay, we also have bradypnea, which means slower breathing, or tachypnea, which is fast breathing, but it's also related to heart rate. So it's just basically how fast or how slow. And again, heart rate increasing greater than 100. So yes, you're out of your normal range, but how are you feeling? You might have had stress, or you might have had too much caffeine, or whatever, and so your heart rate. Fever also can increase your heart rate. So those are kind of things to look at, again, to see if the person is symptomatic. And the reason that we're concerned with even higher than 100, like greater than 140, is when your heart's beating super fast like that, it doesn't have enough time to fill. Okay, so that time for the filling time is definitely decreased, so that can affect your cardiac output, because again, your stroke volume is decreased because it doesn't have enough time to fill. But we'll talk more about that later. All right, so 60 to 100 then is your normal kind of range for heartbeat. So as we talk about, again, stroke volume, so stroke volume then is the amount of blood pumped by the left ventricle of the heart in one contraction. Okay, so that's why it's important when I'm referring to the fast heart rate or the slow heart rate, is if you have it too slow, then your stroke volume is going to happen at a slower rate, and then that affects your cardiac output, and we'll talk more about that here probably on the next slide. And then again, if your heart rate's too fast, you don't have enough filling time. There's not enough time for it to fill. So we have a range of about 40 to 80. 60, kind of a normal range, or a normal number for your stroke volume. So that's usually about 2/3 of your blood that is ejected with each contraction of that ventricle. So there's about 1/3 still left in there. We don't eject all the blood. We still have some of it left. Okay, so there's about 1/3 that's left in the ventricle after each beat. Okay, so the yellow kind of there is representing, on that slide, is representing your stroke volume. So how we determine cardiac output then is we multiply the stroke volume, so the amount that's being ejected every time a ventricle contracts, or your left ventricle contracts, times the heart rate. So how many times does that happen in a minute? Okay, so you multiply those two numbers, and then that gives you your cardiac output. Okay, so keeping in mind that your stroke volume is generally in mils, okay, and then times your heart rate, then you would convert that to liters. So if we just play with some numbers here, if we say that our stroke volume is 60 mils, okay, so that's in the middle of 40 and 80, and we multiply that by 80 beats per minute, Okay, that's going to give us what, 4,800? 4,800. If we multiply 60 by 80, that gives us 4,800 mils per minute, or we usually convert it then to liters, so that would be 4.8 liters per minute would be the cardiac output. And that would be a normal range, because 4 to 6 liters per minute is considered a normal range. Okay, so that's how you calculate cardiac output. So that's something you're going to memorize. You want to memorize stroke volume times heart rate equals your cardiac output. So that's where you can kind of see how the two kind of balance each other out. So again, when I was mentioning, if you have a high heart rate, so your heart rate number is high, but your stroke volume is low, that could be, that could compromise you if you don't have enough filling time. Okay, that's where somebody can become symptomatic. And then maybe your stroke volume is okay, but your heart rate is too low. Again, then it's going to affect your cardiac output. And again, we're really only concerned, too much if we're symptomatic. And like I said, we'll talk more about that. So there's different factors that are affecting your cardiac output, and you want to memorize these for sure. And we're going to define them more in the next few slides, and we'll be talking about them a lot more too in CV diagnostics. And these factors are known as preload, afterload, and contractility. Okay, so make sure you know those 3 things: preload, afterload, contractility. So your preload, I'm just going to kind of give you a little preview of what preload is, and then we're going to talk about it more so in the next few slides. So your preload is the volume of the blood that's in the ventricles during that relaxation period, or after the contraction. So the preload is the volume of blood in the ventricles during that relaxation or during the diastole period after the contraction. So it's kind of like the amount that was left over after it contracted. So after the 2/3 about was ejected, you have that 1/3 left, and that is your preload. Okay, so the volume of blood in the ventricles during relaxation after the contraction is preload. Your afterload is the resistance that the ventricle has to pump against. Okay, so when you have pulmonary hypertension, you have certain situations that constrict your vessels, so you'll have increased afterload. So you have to have increased pressure, so that ventricle has to pump harder. So think about it as like a door that you're trying to open, and you have someone on the other side pushing against you, giving you that resistance, and you're not able to open that door. Okay, and that can be caused by some vasoconstriction going on, which happens when you're hypoxic, when you're low with oxygen. It can happen when you have too much fluid on board. So if your kidneys aren't functioning well and you have a backup of fluid in your system, so you're fluid overloaded, so you have too much blood to kind of push against, so you have too much volume, and that's going to increase your afterload. So it's going to increase your resistance, and when you think about that, that's going to make your heart work harder. Okay, so we'll talk more about that. And then the contractility, the actual strength of the contractility, the ability that the muscle has to actually contract. So that's why obviously important to keep the vessels opened up, your coronary circulation in good, healthy, so that your the strength of your muscle is in good shape. Okay. All right. This next slide here kind of talks about it again in just a different kind of format. Again, showing you how stroke volume times heart rate equals your cardiac output. Okay, so stroke volume then is affected by those 3 things. Again, preload, which is the volume of blood filling the heart. Okay, so that's going to increase your stroke volume if you have a lot of blood filling the heart. And then your afterload is the resistance to blood pumping. So if you have an increased afterload, it's going to decrease your stroke volume because you have too much resistance to push against. And then your contractility. Okay, so that's determining the strength of the contraction. All right, this is kind of a little bit hard to read here, but I'll read through it with you because I have it also written down here on my little slide. So again, this is kind of another analogy, a different little picture to kind of give you a visual aid. So your preload there, you're looking at, what's being dumped into that right atrium, the right ventricle. So it's the volume of blood in the ventricles, again, at the end of diastole. So it's the end diastolic pressure. And you're going to see that preload increased in situations of hypervolemia. So obviously if you have more volume available, and then so you'll have increased preload, and then regurgitation of the cardiac valves. So if your valves aren't functioning properly and they're not ejecting the amount of blood, they're not moving the blood forward like it should be, you're going to have more left over. So that's going to increase your preload. Okay, so also something else I want to talk about with preload. Preload is the amount of tension in the myocardium of the ventricular walls. Okay, so if the walls are stretched by an increase of the amount of blood, so if you think about how much volume, so you've stretched those muscles, okay, you've stretched it because you have more volume, the more forceful your contraction is going to be. So it's kind of like a rubber band, and that's known as that Frank Starling's law. So you think about when the more you stretch a rubber band, it's going to snap back harder. Okay, so that's kind of like preload. So you kind of stretch out those cardiac muscles in the myocardium, and it's going to contract harder. But you have to be careful because you can actually overstretch and you can damage the muscle. So you want to make sure that doesn't happen. So we don't want to be chronically fluid overloaded because over a period of time it will damage your heart. So then afterload, if you look at the picture there, it's kind of showing like a little clamp basically. So you can look at it as a clamp or a door or whatever is the best visual for you. Some kind of constriction, something that's actually restricting the amount of blood being, increasing the resistance out of the left ventricle. So afterload is the resistance the left ventricle must overcome to circulate the blood. So there's some type of resistance there. Okay, it could be, again, like I said, you're vasoconstricted for some reason, so your hose is tighter, or maybe you have a lot of volume on board, so it's harder to push against it. So so this is increased again in hypertension, which is in vasoconstriction. So if you have an increased afterload, it's going to lead to increased cardiac workload. Again, you're working the heart too hard. Okay, the muscle is going to become fatigued, and then things are going to back up more. So you get into this vicious cycle. So there are a lot of patients that end up like this, like if they're fluid overloaded, that's why they give them a diuretic. They give them something like Lasix to help them pee off that fluid, to help them get rid of that fluid. And then part of our treatment too for patients that come in with congestive heart failure, so left ventricular failure, they can't push the blood out. Okay, their left ventricle is failing them, and a lot of times it's related to fluid, is that we put them on CPAP. So we put them on pressure, with a mask. We could do it with a mask, or if we have to, we can intubate, but we really try to avoid intubating. Put them on a CPAP mask, and about 10 centimeters of water pressure. CPAP kind of helps, 8 to 10, can help actually push that fluid back out of the lungs. Okay, so kind of a cool thing. And it can help buy time. So it gives the patient, because they come in, they're increased respiratory distress, they're leaning kind of forward, they can't breathe, they sound wet, they kind of sound gurgly almost. Some of them are to the point where they're in pulmonary edema, where they're actually coughing up kind of pink frothy stuff. but a lot of times you just listen to their lungs and they sound really crackly and really junky, and they'll do a chest x-ray. We generally put them on the CPAP, or sometimes we put them on BiPAP, the two different numbers, and you'll learn about that too. And that just helps them to kind of, till we get their oxygenation up, put them on supplemental oxygen, and then give them the diuretics. The nurses will administer the Lasix, but the doc orders, and hopefully, you know, within 30 minutes to an hour, they're able to get rid of that extra fluid. And then generally they can come off of the CPAP. Alright, now we're going to talk a little bit about the electrophysiology of the heart. So what's actually going on with the heart rate and all the different currents and stuff. So the contraction of the heart is initiated by an electrical stimulus, and there's the contractions are basically a function of these electric currents, or these action potentials that happen. Okay, so the action potentials consist of 5 different phases. So we're kind of looking at what's going on with sodium, potassium, and calcium traveling in and out of the cells, because that different movement is what causes the contraction. Okay, so like I was saying, so we're looking at just the different, you have a video coming up here in a couple slides, that's a link, and I really recommend that you watch it. You may have to watch it a couple times. I just want you kind of to understand the concept. So you're looking at sodium and potassium, sodium coming in, potassium going out, calcium going in, and more potassium going out. So what's happening here is you're having different phases. So we're going to kind of look at, you see the numbers that here are on this little drawing. You have this flat part here that's 4, then you have 0, 1, 2, 3. Okay, so I'm going to kind of explain briefly what is going on with each of these phases. So in phase 4, okay, that flat phase, basically, that is really the resting phase. Okay, so it's kind of that little bit of kind of a pause in between each beat that's going on. So when you're looking at phase 0, where it shoots straight up, that is where the sodium is rushing into the cells, and that's when it's depolarizing. So there's depolarization going on. Okay, so depolarization is a rapid increase in the membrane potential. Once it starts, it goes until the sodium channels then slam shut. Okay, so the sodium channels rapidly go in and making the contraction. So when you're thinking of depolarization, that's kind of synonymous or same or whatever to the contracting. Okay, so depolarization is contracting. Okay, then you have phase 1, and that is basically your early repolarization. Okay, so you've had the spike there. Okay, so the closure now of the fast sodium channels are happening, and you're starting to repolarize. Okay, and that is kind of corresponds with the R and S waves of the EKG, but we'll talk more about that later. So again, repolarization is kind of now you're starting to relax. Okay, so that you have that good spike there, and now your repolarization is phase 1. Phase 2 then is your plateau phase, where you're just kind of chilling out there for a second. Now, keep in mind this happens like in milliseconds. And then phase 3, as you're kind of coming down the slope there, you are in the repolarization phase. Okay. I want to say something a little bit more about phase 2. Again, that plateau phase. So that's kind of sustained by the balance between the inward movement of calcium and the outward movement of potassium. So that's kind of what's going on there. It has a long duration compared to the other nerve and muscle tissues. This normally helps block out any premature signals that might happen. Other muscle tissues can accept additional stimulation and increase contractility, and it helps correspond to the ST segment. So it helps kind of protect the heart, basically. Okay, so again, we have phase 4, which is our resting phase, and the EKG book talks a little bit more about these phases too, so you can refer to that. Excuse me. Phase 0 then is that rapid depolarization where it kind of shoots straight up to 1, and then you start with that early repolarization phase where you're starting to relax. You have the plateau phase there, phase 2, and then repolarization of phase 3, and then the cycle starts all over again. Okay, so yeah, that plateau phase, the calcium going in this upper right here, calcium in, that's what helps prolong the contraction of the heart. So positively charged ions enter the cell during that depolarization, and then the ions enter or leave during the resting cell membrane. Potentials then changes. But just remember that depolarization is like the contraction, and repolarization is the relaxation phase. All right, and so these are, I know they're sort of out of order, but they're in order of the drawing on the previous page there. So it's just kind of naming them. All right, so again, depolarization then is that phase 0, or the electrical activity that triggers the contraction of the heart muscle. And then repolarization is kind of the restoration of the polarized state across the membrane, and it's in the muscle fiber then following the contraction. So both of your fill in the blanks are contraction, but so the depolarization is that contraction phase, and then phase 1 through 4 is the repolarization. So make sure you click on this link and watch that video. It's, I don't know, maybe 7 minutes long, I want to say, but it kind of helps. It has a nice little kind of cartoonish kind of thing that kind of shows the sodium pump and the potassium pump and how the different action potential of the membranes change. All right. So our cardiac cells and our contractile muscle fibers, that's basically the bulk of the myocardium that's responsible for the pumping activity of the heart. Okay, so that's some of it. Some of the cardiac cells are the contractile muscle fibers. Okay, so that's the bulk of it. And then you have these autorhythmic cells. So you have pacemaker cells, and 1% of the tissue, mostly which is located in the SA node. Okay, so that's kind of where the initial part of the contraction starts in that SA node and then travels throughout the heart. So 1% of the tissue, mostly located in the SA node, and it has this really cool ability to spontaneously initiate an action potential, which then is going to make the muscle fibers contract. So kind of a cool and complicated, I guess, process. All right, so there's 4 different properties that the cardiac cells have, and we're going to talk about those here in just a second. I just was looking at something. Okay, so we have the automaticity. Okay, so that generates that action potential without any stimulation. It just happens. It's the unique ability of the SA node. Okay, sinus atrial node. So it's in your right atrium. That sinus atrial node is what that stands for. Okay, so that's where the term normal sinus rhythm, you might hear that somebody's in a normal sinus rhythm, or NSR, normal sinus rhythm, because it's coming from the sinus. It's being initiated from the SA node, which is where you want it to be. Okay, so that's your primary pacemaker of your heart. Okay, and we do have backup pacemakers in our heart. And as we move down the conduction system, the heart rate slows. So the ability to for the heart to pump becomes less as if the SA node goes out or for some reason is damaged, which can happen with a heart attack, then your AV node takes over. But again, I'm getting a little ahead of myself, but we'll talk about that actually in a couple slides. So anyway, so that automaticity, so that's an important terminology. And then your excitability or the irritability, okay? The ability of a cell to respond to a stimulus or irritation. So the lower stimulus is required, the more excitable it is, okay? So if it doesn't take that much to get it into a different rhythm, then it's more excitable. Okay, so meaning like, I mean, certain things can throw people in different rhythms, kind of mainly more electrolyte imbalances than that, but yeah, so that's what the excitability part means. Then your conductivity is transmits then your electrical current effectively cell to cell via those intercalated it's intercalated discs. So it's INTER and then CALATED. I don't know why I say calculated. It's calated. Intercalated discs. And then the contractility then is shortening and contraction, as you're filling the blank, of the muscle fibers that's in the response to the stimulus. Okay. So you're filling the blanks then are intercalated discs and shortening and contraction of your muscle fibers. Okay. All right. So this is what I was talking about here a little bit. So we have these 4 different structures that are basically embedded in the walls of the heart muscles that help generate these impulses and conduct them rapidly through the heart wall muscles. Okay, so you can see the SA node there, your sinus node, that's what that is. The little yellow thing there on top, sinus node, that is where initially, if in a healthy heart, where the impulse begins. Okay, so the electrical impulse then spreads from the sinus node throughout the left and the right atria. Okay, and then it travels to the AV node, okay, the atrioventricular node. So it's kind of between both, you know, like in the septum area. Then it travels down the bundle of His, so that's kind of where it's joined there. So then the electrical impulse spreads from the bundle, or else the bundle of His, and then it goes to the left and the right bundle branches. Okay, so electrical impulses spread from the bundle branches through the right and left ventricles. So that's how it travels then. So you got the SA node, the AV node, the bundle of His, and then you have your left and right bundle branches, and then it spreads out even further into your Purkinje fibers, which you'll see here coming up in a couple slides. Okay, so that's kind of how the impulse travels. And keeping in mind, if something happens to your heart where those areas of your heart are damaged, then there's certain other pacemakers in your heart that are able to kind of take over. But as you get further down the electrical pathway, keeping in mind the heart rate actually starts to drop, because those areas are not as effective, and then you may eventually need to have a pacemaker. Alright, so here is what I was talking about in more specifics. So we have, again, the SA node, which is in the upper right atrium, and that pacemaker is at our normal heart rate at about 60 to 100 beats a minute. That's kind of the boss of the heart. Okay, so you want to have a healthy right atrium, a healthy SA sinoatrial node for your heart to function properly. If for some reason that were to fail or not fire properly, then your AV node takes over. Okay, so that's located behind the tricuspid valve, kind of in the lower portion of the atrial septum, kind of in the area there in between. And that's considered your backup pacer. And then you can see that that heart rate is definitely a lot slower. It's only 40 to 60 beats per minute. And then you travel further down the AV bundle, or that bundle of His, before it breaks off, and that's located then in between the septum and the interventricular septum, and it's even a lower heart rate of 20 to 40. And then that bundle of His breaks off then into the left and right bundle branches. Okay, so you can actually have like bundle branch blocks, and you'll learn about that in CV diagnostics, where something is damaged to that bundle branch and one of the ventricles contracts before the other because there's some type of delay or blockage. And you'll also learn about heart blocks. So kind of cool stuff. I like the heart. I think it's really kind of fascinating. So then after you split to that left and right bundle branches, and that's in the ventricles, then you have the system, the electrical system continues on to those Purkinje fibers, and those are located in the actual endocardium of the tissue of the heart itself. Okay. So kind of here's a little bit more of a visual. So you've got the SA node there on top, number 1, then your AV node, which is again your secondary pacemaker, and then you go to your AV bundle, which breaks off to your left and right bundle branches, and then you can kind of see number 4 there where your Purkinje fibers. So kind of think of those as like little fingers, little extensions, branches off of the larger bundle branches. Okay, and just to kind of blow your mind a little bit more, that electrical system, that conduction happens in 0.22 seconds it takes to travel from the SA node to the Purkinje fibers. That's how fast it happens. In 0.22 seconds, that conduction is that super fast. Okay, so that's going to do it for today, and we will resume on Thursday live. It was great to see everybody today. This is today being Friday, or no, Thursday. All right, see you later.